Well, now it switched my page again. Oh, shoot. Hold on. Okay. Hopefully we've got this going now. I hope. Except I lost my chat. Hold on. Let me get the chat back. All right. I'm going to go ahead then and start lecturing. This should be recording, so I will post this when we get finished. But again, you know, go ahead and try to send me questions or type in questions as we go through, because that'll make this a little bit better as far as more being a little more interactive. Okay. I'll put this over here so I can see it. All right. So we're doing chapter 6, second part of chapter 6. And starting with admission to the hospital, why women come to the hospital or when we need to tell them to come to the hospital. And we need to do that when they start having regular strong contractions, when they are consistent, instead of inconsistent irregular contractions, when they're having regular contractions, when the frequency and the duration of the contraction increases. And again, if you're not familiar with what I mean when I say frequency and duration, those were just terminologies that you need to be sure that you go back and look up. The contractions are getting stronger, longer, and closer together. If they have SROM, so what was SROM? Anybody can type or speak up. Are you guys hearing me? I did have some chat going, but now I have nothing. Oh, there we go, Cece. Thank you. Spontaneous rupture membranes. So SROM is spontaneous rupture membranes. If we have AROM, that would be artificial rupture of membranes, meaning we did it. A bloody show, that's the mucus plug. When they lose the mucus plug, it's a bloody, pinkish tinged bloody mucus show. They have decreased fetal movement, they need to come to the hospital. And again, we've talked about that, how many, the patient has decreased fetal movement, then we really need to do, advise them to do kick counts. And based on the kick counts, will tell us a bit more about if they are having decreased fetal movement. And obviously, if they have any other health concerns, they need to go ahead and come into the hospital. All right, the nursing role on admission. There we go. Nursing role on admission is to establish a therapeutic relationship with the client and the family. So does the mom have a birthing plan? A lot of people do come in with a birthing plan, and in all honesty, those are the people that usually end up with everything that is not on their birthing plan. They end up with, you know, a C-section, more than one IV, and multiple issues. And I'm not saying a birthing plan is a bad thing. It's just kind of ironic that that does seem to happen a lot. But if she has a written birthing plan, we want to try to follow that. Who does she want in the delivery room with her? Oh, I'm sorry. The audio is going in and out. Okay. Oh, and you can't hear me at all? Let me try not using this mic and see. Well, the mic should help. Can you all hear me better now? Okay. Let me try. I usually record with the microphone just so that it's right here and you can hear me better, but maybe that's not working so well on Zoom. Okay, so let me know if you all are having trouble hearing me again, and I'll go ahead. So establishing, or sorry, where was I? Oh, who does she want in the delivery room with her? Does she want anyone in the delivery room with her? You know, does she want just the significant other? Does she want it, you know, 4, 5, 6 people in the room with her? Who does she want? Does she want an epidural or any pain medication? An epidural is not the only type of pain medication. So does she want, you know, anything to help alleviate the pain? Or does she, you know, is she wanting the epidural as soon as she can get it? Or what exactly does she want to happen? Is she going to breast or bottle feed? Now I see it says my connection's unstable. I don't know why. All right. We need to know if she's going to breast or bottle feed. We need to know if she has a pediatrician picked out. And if so, who the pediatrician is.
Oh gosh.
All right. I don't know why I keep losing a connection. Okay. Let's try this again. All right, let me try again. I'm not sure what's going on. Okay. Oh, this has got to get better, I hope. All right. Does she have a pediatrician picked out? And one of the reasons we need to know the pediatrician is because we will often send testing that we've done in the hospital directly to the pediatrician, and that's the best way for information to get relayed right away, as well as the fact that we will then know that she's got a follow-up plan immediately for the baby. They usually need to be seen within the first 2 weeks, sometimes even in the first 2 days of discharge from the hospital. If she has a male infant, does she want the baby to be circumcised? Not everybody does. It's a choice. There's not a medical reason for it necessarily. Certain cultures prefer not to circumcise. So in particular, especially if certain cultures that I know historically do not want circumcision, and then I come in and they say, yes, they do want circumcision, I try to make sure that they did get that information relayed to them in the language that they understand completely, that what they've asked for. And sometimes that is still what they want, which is perfectly fine. Rooming in. Some hospitals require rooming in for infants, meaning that they have to stay in the room 23 of the 24 hours of the day. So facilities that are quote unquote baby friendly, this is actually a status that you have to apply for, and you have to meet certain criteria to be able to be considered a baby friendly hospital. And if you're baby friendly, you have to have the baby 23 hours a day. The baby has to be in the room with the mom. So there's no breaks in the newborn nursery. There's no to send the baby to the nursery to take a nap. There's none of that. All right, 3 major assessments that are performed upon admission. We've got the fetal condition, the maternal condition, and impending birth. So fetal condition, we're assessing the FHR, the fetal heart rate, assessing the amniotic fluid when the rupture of membranes occurs, and hopefully you recall what we're looking for when we're assessing that amniotic fluid. What are we looking for with that? Yeah, color, amount. What else? Odor. Yeah. And one more thing. Yes, time. Perfect. Remember the acronym? Some people had it as TACO, T-A-C-O, time, amount, color, odor. I did COAT, C-O-A-T, color, odor, amount, time. So that's just one way that you can remember that acronym with that. Maternal condition, we're assessing the maternal condition, assessing the temperature, heart rate, respiratory rate, blood pressure. And then we're assessing for impending birth, signs and symptoms of impending birth. If the mom is grunting or bearing down, saying that the baby's coming, or if we have a bulging of the perineum. We also need to be prepared for a precipitous delivery, a delivery that happens very quickly. So we need to know where a precept kit is, a precept basin, and those are usually, I mean, we have them on our floors, they're in the ERs, they're usually in doctor's offices, OBGYN offices, and they just have literally just a basin with the bare necessities, you know, sterile gloves, some towels for drying the infant, a blanket for wrapping the infant, cord clamps, suction to a bulb syringe to suction. So it's just got the basics. Well, even in the hospital, we can be worried about a precept delivery. It's a good question, Cece, because if they are on, if this patient maybe was admitted as an antepartum, as an observation patient, we may have her in a different unit, on an antepartum unit, and we don't typically deliver on an antepartum unit. So they usually will be in labor and delivery for the actual delivery part where everything would already be set up. They have a table set up for the delivery. So you need a precept basin on your unit if they're on the antepartum unit, or even we used to sometimes house them on the postpartum unit because it was a little bit closer to labor and delivery. If we felt that delivery could happen much more quickly, we would put them in postpartum. But usually these are people that we're trying not to deliver. We've got them there for observation and we're trying to stop contractions, or maybe they've stopped but we still need to monitor them for whatever reason. We need to have a precept basin available to deliver the baby quickly before we can potentially even get them over to labor hall. It's a good question. All right. Additional data collection. Did they get prenatal care? Not everyone gets prenatal care, so we need to know if they got prenatal care. Basic information, we need medical and obstetrical history, allergies, medications, whether the medications are prescribed medications or illicit street drugs that they're using. If you ask very nonchalantly, just matter of fact, I need to know what you're taking, most people will tell you. We need to know about their home environment. Do they have any chronic illnesses, any previous surgeries, things that we would need to know about. As far as their OB history, we need to know their GTPAL. And again, I encourage you to go back and review the GTPAL information, the EDC, any pregnancy complications that they've had, any labs or ultrasounds they've had done, their GBS status. Hopefully you guys remember that's your group beta strep status, and group beta strep is a normal bacteria, a normal flora that resides in a lot of places, but a lot of women will have this is a normal flora in the vaginal area, and it doesn't cause a complication unless you're delivering a baby, and it can be something that can be passed on to the infant and can cause complications with the infant. And we need to know their previous labor experiences. Okay, as far as social history, we need to know if they're having any drug or alcohol use, if they're smokers, what is their marital status, any history of domestic violence. I usually just ask very factually, you know, is there any history of physical, sexual, verbal, emotional, mental abuse? And people will tell you. Any cultural and religious considerations. Okay, so if you ask in a non-judgmental way, you'll hear a lot of good stuff. Okay, and that's what you want to hear. And you also have to present it the fact that you are doing this to be more helpful to the. It's not because you want to condemn the patient. It's because you're trying to get the information to be able to perform the best care and keep the baby safe. And when you present it like that, they're much more compliant. All right, admission procedures. We need to get the consent form signed. They need to get an ID bracelet put on. Laboratory tests need to be done. Let's see, I am just going to go through and mute those of you that I can see are not muted. Only because I can hear stuff in the background. I don't want it to bother. Okay, I can't tell who it is. I can hear somebody in the background, but I can't tell who it is because I've got most people on mute, I think. Okay. All right. Make sure your consent forms are signed, get an ID bracelet, laboratory testing. If there's any tests ordered, which there usually are, blood work, just a basic blood panel to be drawn, a perineal prep, an IV started. Pretty much everyone gets at least one IV, and we need that in case there's an emergency and we need to take her back to the OR. We need to get her some medications quickly. A perineal prep if delivery is imminent. We'll just do it. We'll do a quick little betadine prep in the vaginal area. And we need to be determining the fetal presentation. So we can do that with Leopold's maneuver. And so we haven't really talked about that a lot, but I think it was on one of your worksheets maybe. But Leopold's maneuvers where you're physically doing your hands on the abdomen like this picture here, and you're really trying to find where the spine is. You're feeling for the firmness of the fetal spine and the curvature or the softness, so to speak, of the fetal face and legs there, and you're feeling then at the top of the fundus for more, it's gonna be firm but a little bit softer there versus the bottom of the fundus where you can actually feel the head and hopefully feel that the head's engaged. So I know that there are some good pictures in your book on Leopold's specifically to help you better grasp how you need to do it, because you have to actually stand in different positions to do Leopold's maneuver correctly as well. But you do Leopold's maneuver. We're trying to determine the fetal attitude. Remember, attitude is the fact that we want the baby's head to be flexed all the way down. The position, that's whether the baby's in ROA or LOA. Fetal station, if the fetal head's at the level of the ischial spine's at 0 station, +1, +2, +3. The cervical dilation, 0 to 10 centimeters dilated. And cervical effacement. We need the cervix to be 100% effaced before we go ahead and try to push. All right, the cervical or vaginal exam. So when should vaginal exams be done? All right, we don't need to do vaginal exams like all the time, okay, to determine how far along you are. We should be doing them as part of a nursing assessment to reveal that labor is or is not progressing. We want to do a vaginal exam before the administration of medications, because certain medications may slow down that the dilation process. So we're going to do that before the administration of some medications. We will do a vaginal exam when we have the spontaneous rupture membranes, because we need to know how far dilated we are. When we have sudden onset of deep variable D cells or early D cells. And if we have that, why do you think that we're doing a vaginal exam then? If we have this sudden onset of deep variable D cells or early D cells. Yes, Cece, we are worried about the baby for a couple of reasons. Yes, making sure that they have oxygen, yes. So if we have deep variable D cells, we're concerned that maybe we do have a cord prolapse or a nuchal cord. So we're assessing that. And early D cells, we're concerned that early D cells are good, those are fine, but we're thinking labor may be progressing more quickly than we thought it was. So that's why we're going to do another cervical or vaginal exam. And then if the mom complains of what, are we going to do another vaginal exam? Yeah. Yes. Yes. If she's feeling pressure, rectal pressure at all, and feeling like she needs to have a bowel movement or saying that she needs to push, yes, good. We're going to do a vaginal exam, see how far along she is. Now, vaginal exams are, we've talked about it, they are an invasive procedure, so we don't want to do a vaginal exam if the patient presents with any type of bright red, painless vaginal bleeding, because we think that may be what? Bright red, painless vaginal bleeding. Yes, Kelly, placenta previa. So if she presents with bright red, painless vaginal bleeding, we're concerned with a previa, and we definitely don't want to be doing a vaginal exam and causing more stimulation, more bleeding of that placenta there. Okay. You all can unmute and talk to me. You don't have to just do chat. Either way is fine. All right, danger signs during labor. The blood pressure is greater than or equal to 140/90 or less than 90. OCC said, are LPNs allowed to do vaginal exams? In all reality, most of the time LPNs are not working in the hospital and doing these. But you know, way back in the day, yes, they used to, and I feel like things are trending both ways now. But you need to understand, you know, if there was an emergency situation that came up, and then you may be asked to do that, but you all would be definitely working in, could be working in doctor's offices as LPNs. And again, you still are not technically the ones that would be doing the vaginal exam. The physician would be doing that, but it's good to know what they would be assessing for. I mean, honestly, I didn't hardly do that many vaginal exams. You kind of get the nurses that worked in labor and delivery primarily did the vaginal exams, because that's what they were doing every day, all day. When I worked in labor and delivery, I was there doing triage, so I was not working back in labor and delivery all the time. I was working mostly in newborn nursery and postpartum. So I didn't really even do that many vaginal exams, because it's really hard to determine what am I really feeling if you're not feeling the cervix over and over and over again, to get the feel for how far dilated things are. All right, so the danger signs: blood pressure greater than or equal to 140/90 or less than or equal to 90/50. Temperature greater than or equal to 100.4. If the amniotic fluid is green or yellow or brown, what do we think might have, why would the amniotic fluid potentially be green, yellow, or brown?
Meconium.
Yes, perfect, thank you. Meconium. If there may be a foul odor to the amniotic fluid, what might that be from? Infection. Kelly says infection. So infection or meconium can cause that foul odor. And sometimes the amniotic fluid would be a cloudy color. What would potentially cause a cloudy amniotic fluid? Yes, the field infection again is a reason why we may have cloudy amniotic fluid, because remember, we want it to be clear. It should be clear, odorless. So we have a green, yellow, or brown would indicate meconium. A foul odor would indicate infection or meconium, and cloudy amniotic fluid would indicate potential infection. Also, another danger sign would be a non-reassuring fetal heart rate pattern. So if the fetal heart rate tracing is showing decels in the fetal heart rate tracing, that the baby's heart rate is going down. Sometimes this is okay, and we're going to talk about that as we go through this lecture, but depending on what the decels are, that can be what we call a non-reassuring fetal heart rate pattern, which is not something, it means that there's some distress. Because remember, the best way we can tell about what's going on with the baby is by doing these non-stress tests and determining the fetal heart rate along with the contractions. So Cece was asking, are we worried about meconium? And yes, we are worried about meconium, other than aspirating, which is clearly an issue with the meconium aspiration, because then it can get into the lungs and cause a respiratory infection. That is really their primary concern with meconium, but it will also in utero cause fetal distress. So if we see this green, yellow, brown amniotic fluid or foul odor, we really want to go ahead and try to get this baby delivered more quickly if we can, because the longer the baby stays in there, the worse things are getting, because we don't know how long this meconium has been harboring in the amniotic fluid. So the infants are usually in fetal distress, so that will show up on this. We will get this non-reassuring fetal heart rate pattern again with the oftentimes with meconium. Oh, that's a good question. Do you record that as the first bowel movement? You can. Yes, you can. You want to have them when, it's a good question. But yes, you can record that as their first, because sometimes that's what happens. We'll be like, oh, this baby hasn't had a bowel movement for 24 hours. And we want the babies to have a bowel movement to pee and poop within the first 24 hours. So if we're not getting, if we haven't had that bowel movement, we start getting really concerned. But yes, if we can go back and track in the chart, in the nursing notes and everything that the baby had meconium, then yes, we can technically count that as the first bowel movement. I don't know that I say we do normally, but if there's a complication, like we're saying, oh, it's been a while and the baby still hasn't pooped, and then we'll be like, oh, well, wait, the baby did have meconium in utero. So yes and no. I hope that answers your question, Cece. It's a good question. All right. If we have prolonged uterine contractions, if the contractions are lasting greater than 90 seconds, this is a danger sign, because remember, we have to have that relaxation of the uterus for the baby to get the oxygen and blood supply that it needs. So if we have prolonged contractions lasting greater than 90 seconds, then we've cut off that blood supply and oxygen supply to the fetus. If we have heavy or bright red vaginal bleeding, we are concerned about a possible abruption. If the mom complains of unrelenting pain, this, extreme abdominal pain that's just not letting go, not letting up at all, we're concerned about the two things, about hypertonic contractions, these prolonged contractions, as well as a potential abruption, because they have that really bad abdominal pain with abruptions. Right upper quadrant pain. We're concerned about right upper quadrant pain. That's a danger sign during pregnancy, because we're concerned about the liver, and we would be concerned about the liver because of preeclampsia. Okay. And then visual disturbances. Again, this goes along with preeclampsia and eclampsia. And so we will often ask them, are you seeing any, do you see any spots, or what we call scotoma, or blurry vision? Are you having any epigastric pain, which is pain, kind of right here at the bottom of the xiphoid process, but also over here on that right upper quadrant area, and any headaches. And those are the things, excuse me, that we typically will ask to patients that have potential for preeclampsia. Yes, well, that is hypertension. It's pregnancy-induced hypertension, Cecile. Preeclampsia and eclampsia. All right, nursing role, first stage of labor. So in the first stage of labor, what is the first stage of labor called? Not pre-labor.
It's one.
Dilation, that's part of it, Cecile. What's the other part? Dilation and effacement. Yes, dilation and effacement is the first stage of labor, and it has 3 subcategories. What are those? Latent is one of them. Yes, Robin. Effacement. Dilation and effacement. Latent is the first stage, 1 to 4 centimeters. There were 4 subcategories. No, not ripening. Remember, we had the different stages of labor. The first stage of labor was called dilation and effacement, and under dilation and effacement, we had 3 different subcategories. One of them was latent. That was the first one. That was 1 to 4 centimeters. And then you had another one and another one. Okay, transitional, Victor, that is in there. That's the third, that's the last one. That's at 7 to 10 centimeters.
Active.
Active, yes, active. Active was the middle one. So we have dilation and effacement is the name of that first stage of labor. Then it had the 3 subcategories, which were latent at 1 to 4 centimeters, active at 4 to 7 centimeters, and transition from 7 to 10 centimeters. Good. All right. So during the first stage of labor, we're doing the maternal and fetal assessment, doing the physical and psychological care with the mom. We're keeping the doctor notified of the labor progress because they are not sitting in there waiting for this. So we're kind of keeping everybody on top of things, promoting relaxation, and we're concerned with, promoting safety for the mom and the fetus. And there is, I think that is the correct page number, table 6.6 on page 155 and 156 in your book. That has information for you. All right. And then the nursing role in the first stage of labor, the vital signs, we're going to do the temp every 4 hours if what has happened. Because here's the thing you can see on here, we're going to do a temp every 4 hours if one thing is going on. We're going to do a temp every 2 hours if something else is going on. So what are those things?
Rupture of membranes.
For which one? Who's talking to me? That was Crystal, I think, wasn't it?
Yes, I said rupture of membranes.
I thought it was Crystal. All right, so which one, Crystal? Is that if you're going to do the temp every 4 or every 2?
I would say every 2.
Correct. So if you have rupture of membranes, we're going to do the temperature every 2 hours if we have rupture of membranes. So when are we going to do it every 4 hours? Before the rupture, yes, Kelly. So when the membranes are still intact. So the temperature is every 4 hours if the membranes are intact, every 2 hours if we have rupture of membranes. Okay, we're doing the blood pressure every 1 hour for the latent and active phases of labor. You need to assess for pain every 1 hour and PRN. We're monitoring the I's and O's. Mom is usually NPO during labor related to the high risk of aspiration and from vomiting if she needs a C-section. Now that's kind of controversial still. People are going back and forth on whether or not they're allowing patients to eat or drink during labor. But I don't know, it's been a while since I was in the hospital. It's been a couple of years, but even not that long. And before I left, we were still having patients be NPO because the risk for needing that emergency section is there for sure. And we need to keep everybody safe. The best option is to keep her NPO or just ice chips so that we can decrease that risk. Yeah, well, that's why, Cece. Yeah, that's okay. So that's why, it's mainly just because we're trying to prevent the risk of aspiration, because we have a potential to have to go back to the OR pretty quickly to deliver. If things don't go well with the baby, we can see that things are not going well. We need to have an emergency section. If we've kept the mom NPO during labor, just ice chips, then we're good to go on getting her back to the OR and getting that baby out. All right, we're going to encourage voiding every 2 hours because we want the bladder to be empty for delivery. You don't want a full bladder there blocking the passage of the fetus. So we're going to encourage voiding every 2 hours. Encourage position changes, breathing techniques, personal hygiene care, do frequent linen changes, especially if the mom has ruptured her membranes. nobody wants to sit there in that wet mess and it's just harboring germs and bacteria and potentially causing problems. So if you have a patient whose membranes have ruptured, then you need to be changing those linens pretty frequently, which is not obviously a whole full bed change, but that's why you're putting chucks under her. And oftentimes we'll put towels between her legs to try to collect some of that amniotic fluid. And we're just changing those towels real frequently and changing the chucks frequently so that she's not sitting there in the wet moisture. Be sure that you keep the patient and the partner informed of the labor progress, because one of the things that happens, and this happens in all aspects of nursing, is that we know what's going on. And so we tend to just assume, we forget that they don't know what's going on. This is not routine for them. And so we need to be sure that we keep them informed of how things are progressing with labor, because they are unfamiliar with it. While for us it's routine, it's unfamiliar for them. Victor, what were blood pressure every 1 hour for latent and active labor? The latent phase and the active phase of labor. All right. So nursing care the first stage of labor for the fetus. We're going to assess the fetal heart rate every 15 minutes while the mom is laboring in the active phase, because that's what we're doing in the active phase. Observe for the rupture of membranes. Again, here we're doing the coat, the color, amount, odor, time. We did want it to be clear, odorless. We're assessing for bloody show. This will tell us that the cervix is potentially dilating if we've got that bloody show telling us that the cervix is dilated and the mucus plug, that we're losing the mucus plug. How do we tell if it's rupture membranes or if the mom has peed on herself or is leaking fluid? So how are we going to tell? There's 2 tests that we can do. Can somebody tell me at least one of those tests? A pH test? Yeah, it is a pH test, Cecile. It's called a nitrazine test. And you put a sample of the fluid, the vaginal fluid, on nitrazine paper, the same paper that you used for NG. Couldn't think of it. Same paper used for NG. And if it turns, what color does it tell you that she has ruptured her membranes? Yes, Cecile, it's blue. If she turns blue, it means she's ruptured her membranes, because alkaline, amniotic fluid is very alkaline. Okay, thank you. What is the other test? So the first test is a nitrazine test. What is the second test to tell if it's ruptured membranes or if she's leaking urine? It is a Fern test. I'm not sure, Cecile, what you mean by taking the fluid out, but it is a Fern test. So Ferning is the second type of test that we're going to do to tell if it's ruptured membranes or leaking fluid. And with Ferning, what you do is, again, you get a sample of the fluid and you put it on a microscope slide. You put it under the microscope and look at it, and it should look like fern leaves. Okay, so I've got some pictures that will show you. I can't even remember which PowerPoint they're in, but they're in here somewhere. But it's also in your book to show you the difference. But those are the 2 tests to tell. This happens all the time. Women come in, they think they've ruptured their membranes because they're leaking, or they're not sure if they've ruptured, or if they're just peeing on themselves because the baby's real low, sitting on their bladder. And so what we will do are these 2 tests, a nitrazine and a Fern test. And it just consists of doing a speculum exam, getting 2 swabs. Usually they'll get 2 swabs in the vagina there to get the fluid that's leaking, and they'll take 1 swab and wipe it on the nitrazine paper, and 1 swab and wipe it on the microscope slide. And then the nitrazine paper will turn right away blue if they have ruptured their membranes. And then they'll also look under this microscope though as well for clarification and see the ferning if yes, auscultating the fetal heart rate. Yeah, I think that's correct, because the next CC, because the next thing says assessing contraction pattern in relationship to the fetal heart rate pattern. So hold on a sec. I think I don't have, I may not have the most recent book home with me. Oh, I do. Let me see. DJ, the first blank was laboring, while the patient's laboring in the active phase of labor. Yes. Yeah, box 6.2. That is the correct box that I was wanting you guys to look at there. Box 6.2 is on page 139. And because it's showing you when to auscultate and document the fetal heart rate. For low risk women, how often do you need to do it? For high risk women and routine auscultations. So that is correct. Oh, the tests, it's not in a box or anything. The tests are, see, I still have my old page number on here. Hold on. I know it's in here. Let me get back to you on the page number on that. Because I still have my old page numbers written on my PowerPoint here. I have some old page numbers, some new page numbers, Cece. So let me make a note because y'all know I'll forget everything. All right, I'll try to look that up because we'll do, oh, it's 8:50. We need to do break already. Oh, this is going to be, let me go just a little bit longer and then we'll, oh, Ashley says 1:44. Thank you, Ashley. 1:44. Sorry. Yep, thanks, Ashley. 1:44 is correct. I'll change it on my PowerPoint right now. All right, thanks. Okay, let me go just a little bit longer because this is taking me longer than I thought it would, and I really would like to get through this. So let me go just a little bit longer here, and then we'll do a break. Fetal heart rate pattern with electronic fetal monitoring. So we've got two different ways that we can monitor. We can do this with external fetal monitors or internal fetal monitors. So we've got external fetal monitoring. This is the most common way that we monitor the fetus. And maternal position, one of the problems with it is that maternal position affects the quality of the tracing on external fetal monitor. So if she is, well, let me just say it's easier to get the baby's heart rate if she will lay onto one side or the other, because then the baby kind of floats up to that side, and then you can get a better heart rate tracing. Intermittent, or we can do this, the external fetal monitoring intermittent, meaning we can put her on for 15, 20, 30 minutes to do that NST, the non-stress test, or we can keep her on for a couple of hours if we need to, or several hours, or all day even. And then we have internal fetal monitoring, and this is applied by a specially trained person. The nurses do not do this. This is, the physicians do this, usually maybe an NP. It's a spiral electrode that goes in and it's attached to the fetal scalp. Literally, they just kind of twist this electrode in under the fetal scalp, just right up under the skin. It doesn't hurt the baby or anything like that. But this is really, during the internal fetal monitoring, is the only way to get an exact fetal heart rate tracing in utero, because it is in the baby's head. We are getting the exact pulsations of the fetal heart rate versus externally where we just have it on the mom's abdomen. This is external fetal monitoring. This is what we do most of the time with external fetal monitoring here. And this one is measuring contractions. This one is measuring the fetal heart rate, okay? But this affects, you know, if she's moving around at all, then the baby moves, and then we're not getting the heart rate, we have to move this monitor frequently to get the good heart rate tracing. And then this is the internal fetal monitoring over here, where we're actually, right here is the fetal monitor, the internal fetal monitor that goes in, and this one has like a little cap on it. They don't all have that, but it literally just kind of screws into the top of the baby's head here and gives us our best, it's the only way to really get a true exact fetal heart rate tracing. And then this goes along with it. This is how we're measuring contractions with internal fetal monitoring, is with something that's called an intrauterine pressure catheter, an IUPC, and it measures the contractions in utero. This one measures the contractions externally. This one's measuring it internally. We're going to talk about that. All right, so some advantages and disadvantages of internal fetal monitoring. Advantages for internal are that it does allow for increased maternal movement, and because it's internal, so it doesn't matter how she moves around, we're still going to be tracing the baby regardless of where the baby is moving, and it allows for continuous fetal heart rate tracings. Disadvantages, what has to happen before we can place an internal fetal monitor? Yes, rupture membranes. Rupture membranes has to happen before we can place an internal fetal monitor, because if we have the bag of water still around her, that amniotic sac around the baby, I mean, we can't place this internal fetal monitor. So rupture membranes has to happen. And what else? The cervix has to be what? Yes, dilated. The cervix has to be dilated at least 2 centimeters. So we have to have at least 2 centimeters dilation, which is not very much. The membranes have to be ruptured before we can do internal monitoring. There is a potential risk for injury and/or infection to the mom and the baby with internal fetal monitoring, only because we are introducing things into the uterus and we are putting this electrode into the scalp. Very rare that you would ever have any complications. Sometimes this, where it goes into the fetal scalp, will get a little, it's not really infected, but a little irritated, and we just put some bacitracin or Neosporin on it, and then it goes away. It's never really been a problem. But internal fetal monitoring is used specifically when we are having difficulty tracing the fetal heart tones with the external fetal monitor. We do use external fetal monitoring primarily because it is least invasive, but if we really need to, if things are not going well, we can't really tell what's going on with the baby, we're having difficulty tracing the fetal heart tones, things like that, then we're going to go ahead and switch over to this internal fetal monitoring. All right, with external monitoring, it uses what's called a TOCO, or toco dynamometer. We just call it a TOCO. We place it on the fundal area. So remember, the fundus is the top of the uterus. As the uterus contracts, this sensor on this little button on it sends a message to the monitor so that we can actually read it on the strip. Now, a external monitor does not measure the true intensity of contractions, okay? So again, here's your external fetal monitor. This one is the fetal heart tones. It usually has this little heartbeat with the US on here, ultrasound, telling us that it's measuring the fetal heart tones. So this goes usually lower because the baby should be head down, hopefully, in the vertex presentation. So the heart rate's going to be lower. And then this one is the TOCO that we're measuring the contractions with, and that one will go up higher. It will go up on the fundus, so on the top of the uterus, to measure those contractions. All right, with internal contraction monitoring, we've got the IUPC that I was telling you about a few minutes ago. This is an intrauterine pressure catheter. It can measure the true strength of contractions. It does require this IUPC to be inserted into the uterus between the uterine wall and the fetus. So that's what happens. This goes in between the uterine wall and the fetus. When the mom has a contraction, you know, and they're pushing the baby out, then that pressure catheter is getting squeezed between the baby and the uterine wall, and that's how they're measuring the strength of the contraction. All right, it measures in millimeters of mercury. And this is a fetal scalp electrode. So you can see this little corkscrew right here that it's just a little metal, very thin wired corkscrew type thing. And this literally they just put this on the scalp and they just twist one time and then it just hooks right in there and it's not harmful. And then this this right here, this hard plastic comes off this sheath. This is a guide. And then as they get the electrode hooked onto the baby's head, they'll pull this guide out so that it's very soft, flexible, flimsy wire, like right here. And this is the IUPC that they will insert. So this gets inserted between the uterine wall and the baby. And then this will measure that intensity of that contraction. As the contractions happen, it'll be pressed between the fetus and the uterine wall to be able to measure the true strength of the contraction. All right. Hopefully that'll get us a little bit. Okay. So if you guys want to, I mean, we got to do like normal class time, so go ahead and take a quick break. I'll probably just do a 5-minute break since I'm already kind of running behind trying to figure all this out. So if you all just do a quick little 5-minute break, I'm just going to pause this recording and everything for 5 minutes, and then I'll be right back. Okay. I'm going to go ahead and try to finish this up. I know that wasn't a very long break, and hopefully I'll get better at this so that I can move through this more quickly. But I was just telling Kelsey, I'm not sure what's happening at 10 with lecture with Miss Smith. I've got to get this done regardless, so I'm going to keep on going. And if you want to stay on, you can stay on. If you need to get off, you can get off. It's going to be recorded so that it can be posted because I would have to record it anyway. So I'm going to go ahead and try to, well, I am going to finish this lecture. All right, so assessing fetal heart rate pattern. The PN role in evaluating the fetal heart rate. The OB nurse is responsible for evaluating and monitoring the fetal heart rate patterns. The practical nurse must be able to differentiate between reassuring and non-reassuring fetal heart pattern and to get assistance when needed. So that's the primary reason why you need to understand these fetal heart tones and the fetal heart rate tracings, is because you need to know when to notify someone else. If it's a reassuring fetal heart rate pattern, that means that the fetal heart rate indicates that the fetus is receiving adequate oxygenation and is not in distress. If we have what we call the non-reassuring fetal heart rate pattern, this indicates that the fetus may be experiencing distress and or hypoxia, which could be from cord compression or uteroplacental insufficiency. So page 141, box 6.3. Has some more good information about that, so be sure that you've looked at that box. All right, this is a reactive NST. A reactive NST, that's what we want. So this would be a reassuring fetal heart rate pattern. That means we have the presence of 2 or more fetal heart rate accelerations during a 20-minute period, with each acceleration of 15 beats per minute, lasting 15 seconds or more. Right, usually occurs simultaneously with fetal movement. So remember, we've done this before. We talked about these little long lines down here are when they give the mom that little button to push, and she pushes the button whenever she feels the baby move. And so you'll notice she's pushed the button here and we had fetal movement. I mean, well, she felt fetal movement and we have a fetal heart rate acceleration here. She feels fetal movement, we have an acceleration. Fetal movement, acceleration, okay? The tracing is extended to 40 minutes before we comment or say that it's a non-reassuring or a non-reactive NST. And if it's non-reactive at that point, then we need to notify the physician, and they will tell us whether they want us to keep the patient on the monitor a little bit longer for extended monitoring, or if they want to come over and do that biophysical profile, the BPP. All right, non-reassuring fetal heart rate. We have to notify if we see a non-reassuring fetal heart rate pattern. We need to notify the nurse and the physician. We need to change maternal position, preferably put her on her left side or in the kneaded chest position to increase that blood flow and decrease the compression of the fetus on the superior vena cava. We're going to stop Pitocin if we have Pitocin running to induce labor or to help with the contractions. We're going to stop that. Victor said, does that mean 2 reactions within 40 minutes would also be considered reactive? And no, it has to be two 2 accelerations of 15 beats per minute lasting 15 seconds in 20 minutes. So even if we may keep them on extended monitoring for up to 40 minutes, but it's still, they have to have those 2 accelerations within 20 minutes to be considered reactive. That's a good question. We may need to give her an IV bolus if we've got non-reassuring fetal heart rate pattern. Give her oxygen at 10 liters per face mask. We are going to observe for a prolapsed cord and prepare for imminent delivery or C-section if we do have a prolapsed cord. Check maternal vital signs, monitor the fetal heart rate, and reassure the mom and the family, because lots of things are going to be happening if we get this non-reassuring fetal heart rate pattern. Things start getting busy. We need to keep reassuring them everything's okay. We're just checking on the baby. Baby's not looking great at this moment, so we need to figure out what's going on. So we're going to roll you to your side, put your knee to chest, or whatever, okay? When assessing fetal heart rate patterns, you need to know what is considered the baseline. How are we doing a baseline? Bradycardia, tachycardia, accelerations, decelerations. So you need to, you just have to know this so that you can then interpret a strip, a fetal monitoring strip. So the baseline fetal heart rate should be between 110 and 160 beats per minute over a 2-minute period. Fetal bradycardia is below 110 beats per minute for 10 minutes or longer. Excuse me. Fetal tachycardia is greater than 160 beats per minute for 2 to 10 minutes. An acceleration, an acceleration, fetal heart rate increase of 15 beats per minute above the baseline for 15 seconds or more, but less than 2 minutes. You don't want to, if it goes up and it stays accelerated at a different, a heartbeat 15 minutes above the baseline and it stays there for 2 minutes, then that's no longer an acceleration. That's the new baseline fetal heart rate, okay? You want to have accelerations. Remember, those are good things. We want to have those. Now we've got decelerations, which we've got to be careful with, and there's a couple of different types. So we have early decelerations. This is when the fetal heart rate goes below 40 beats per minute below the fetal baseline. This is why we have to have a baseline fetal heart rate so that we know what is going to be considered 40 beats below that baseline. It will be U-shaped. It actually mirrors the contractions, and these are okay. Early decels are fine, okay? And then we have variable decelerations. This is a decrease of at least 15 beats per minute below the baseline fetal heart rate, lasting 15 seconds to 2 minutes. These are going to be V-shaped or W-shaped or U-shaped, and I'm going to show you some pictures here. And they need intervention. So variable decels need intervention. We've got to do something for these patients. Late decels, they look like early decels, but they begin after the contraction and they don't return to baseline until after the contraction ends, and those are bad. Okay, so an early decel, it mirrors the contraction. The decel, I mean, if we have an early decel, the heart rate starts going down. When the contraction starts, it will literally be like a mirror. I can't do that very well. Will literally be like a mirror between the contraction and the fetal heart rate. If the if the fetal heart rate starts dropping halfway through the contraction, or anytime after the contraction begins and comes back to baseline after the contraction ends, that's not good. That's a late decel, and those are bad. All right, fetal bradycardia causes for fetal bradycardia, which was a fetal heart rate of less than 110 beats per minute. Maternal hypotension, vagal stimulation. So this is where we need to get the mom off her back and get her onto her left side if we've got this fetal bradycardia. We could have severe fetal hypoxia, a heart block, or certain medications can cause fetal bradycardia. Things that can cause fetal tachycardia. So this is a fetal heart rate of greater than 160 beats per minute. Maternal or fetal infection, maternal dehydration, maternal fever. So that's why one of those things said that we were checking the maternal, if things were not going great with the baby, we're checking mom's vital signs, and this is why, okay? If the fetal heart rate Let's just say that the baby had a fetal baseline heart rate of, excuse me, sorry, a fetal heart rate baseline of about 120 beats per minute, and about 6 hours after she has spontaneous rupture of membranes, the fetal heart rate now goes up to 168, and that's now the new baseline is 168. What should we do? So our fetal heart rate baseline started at 120, and she's been laboring for a while. This is about 6 hours after she ruptured her membrane. She's still laboring, and now the fetal heart rate is gone up to 168. What should we do? Intervene, the baby's distressed. What do we need to figure out first, though? Yes, why the baby's heart rate is going up. So what's one thing that we could assess on the mom, actually? Vital signs, yes, we're going to assess vitals. Not necessarily position, because that would be more if she had a fetal bradycardia. But with fetal tachycardia, we're really going to jump to the vital signs particularly. And particularly, we're going to be looking at temperature. So if first thing we want to do, if we have this jump, baby's fetal heart rate is in the 120s, and now 6 hours after rupture membranes, we've seen this trending up of the fetal heart rate. Now the baseline's up in the 160s, 168. First thing we need to do is check the maternal temperature, because we're concerned about a possible infection. And mom has an infection, that's going to cause the baby to be tachycardic and be in distress, like Cece was saying. So we are going to end up calling the physicians. You know, the baby's heart rate's now gone up to 168, but we got to tell them something. So we've got to be assessing, you know, things on the mom first, getting her vital signs, checking for dehydration, things like that, so we can give the physician more information. All right, fetal hypoxia can be a cause for tachycardia. Moms given medications that are given to the mom that cause tachycardia, things like tocolytics, we give tocolytics. I hope you remember sometimes to stop contractions, to stop labor, and they can cause tachycardia in the mom, which can then cause tachycardia in the fetus. If the fetus has cardiac anomalies, that can cause fetal tachycardia. And when the mom smokes or uses nicotine or street drugs, that can also cause fetal tachycardia. All right, so these are early decelerations, okay? Early decels, and the nursing action is that there is no particular nursing action that needs to be done. The decel begins and ends with the contraction. So I'm hoping you guys can see my mouse here so I can point this out to you. But right here is about when this decel, this fetal heart rate deceleration begins. And if you'll come down here and look, that's exactly when this contraction begins. So here's the contraction peaks and comes back down. And we look at this deceleration here. And right when the contraction peaks, we're at the peak of our deceleration in the fetal heart rate. This is fine. This is, no action needs to be taken, okay? Then we back up here to our baseline, which is 150, I think that is 150. And we're back at our baseline of 150. So here was our baseline 150. I mean, it's jaggedy, but this is our baseline is 150. We've got this decel here down to 140s, back up to 150, 150. Now we've got this little tiny accel up here, up to about 170. And then we've got back to our baseline at 150, and about right here-ish, we're starting our decel, our fetal heart rate deceleration, which is beginning about the same time as our contraction. And we come down here, here's the peak of our contraction, and we can mark it right with our deceleration. It doesn't line up exactly, but it's very, very close in that mirror. This is good, this is close enough. It's coming right back up, and the baby's heart rate is recovered by the time the contraction ends, and that's what we want to see. We're back to our baseline of 150 before the contraction even ends, and so this is normal. Okay, the fetal heart rate slows with the contraction. That means that the baby's got fetal head compression. This is normal because the fetus is down in the pelvis And we're pushing it down further with these contractions. So this is a normal finding, okay? Then we've got variable decelerations. So variable decelerations, the nursing action is that we need to try to relieve any kind of cord compression or by changing maternal position or potentially doing an amnio infusion where we will insert some extra amniotic fluid. Well, we will put in warmed normal saline, usually through an IEPC, that intrauterine pressure catheter, or we'll put a Foley catheter in, not in the bladder, but actually in the uterus, and flow in this warm solution to try to give the baby more protection so that everything's not getting compressed so much with the contractions. Okay, so variables are a sudden drop in recovery of the fetal heart rate. It's usually caused by umbilical cord compression and needs nursing action. So remember I said it would be V-shaped or U-shaped or W-shaped, and this is very sharp. So here's your fetal baseline at 150s. We have a dramatic drop here down to about 110 and a quick recovery again up here back to 150, our baseline. And we've got a dramatic drop, and there's, if you'll notice down here, there's no contraction happening at all, but our heart rate's dropping down to the 90s even. And here's our W-shaped one right here. And then we're back up recovering, but that had nothing to do with the contraction. And here's a peak of this contraction happens after our fetal heart rate deceleration ends. So while this is close to this contraction, it doesn't mirror it, because here's where this contraction peaks. And if you go up here, that deceleration has already ended, okay? We're back here. This is all still at 150 baseline. Even though it's jaggedy, that's the baseline. It's 150. And then we have, again, another drop in the fetal heart rate here down to the 120s, a sharp drop. This is your V-shaped here, and quick back to the 150s. But again, has nothing to do with the contraction. It's not related to the contraction. So these we definitely have to intervene on and try to help this baby who's in distress. All right, then we've got late decelerations. Late decels begin after the peak of the contraction. The nursing action is to increase maternal oxygen and blood flow to the placenta. So get her off of her back, turn her onto her side. We're going to give her oxygen, fluid bolus, stop the Pitocin if it's running, administer tocolytics if we need to stop the contractions, and again, notify the healthcare provider. So late decels are usually smooth and this nice smooth U-shaped, but they're caused by uteroplacental insufficiency, and it needs immediate action as well. So you'll note here's where this contraction begins. Here's the peak of this contraction, and at the peak of the contraction is where that fetal heart rate deceleration starts. So again, this fetal heart rate is baseline's 150, and we decel down here to the 120s. It takes a long time, and it takes a while to recover up here, but it has nothing to do with, it's not in relation to these contractions at all. So that's not good. So we've got to intervene, changing position, giving oxygen, giving her a fluid bolus, stopping medications if we've got her on Pitocin or anything, and we may need to administer tocolytics to stop the contractions. Oh, excuse me. All right, deceleration. So this is a nice little mnemonic that I think really helps with figuring out these decelerations. I don't know why I never heard of this when I was in school. This probably would have helped me when I was in school. But it's called VL-CHOP. So a variable deceleration is cord compression. Early decels, head compression, and they're okay. A is for accels. These are okay. May need oxygen, but usually you don't need to do anything. Late decels, these are from placental insufficiency. So doing this mnemonic, this VL-CHOP, helps you remember you know, what is causing what. Variable decels are caused by cord compression. Early decels caused by head compression, which is normal. Accels are okay. Late decels are caused by placental insufficiency. All right, more pictures I tried to just put on here to try to help you guys see the relationship here. Early and late decels, it's okay to be early for dinner, but don't be late. Late decels indicate uteroplacental insufficiency. And early decels are head compression. Lates are uteroplacental insufficiency. We need to turn them on. And variable decels are cord compression. All right, so signs and symptoms of increasing fetal distress. The absence of fetal accelerations in the fetal heart rate pattern. So if we're not seeing any of that, any of those accelerations, whether we can count them as true reactive strips or not, if maybe they don't go up 15 beats per minute and last for 15 seconds or longer, but if we have 0 accelerations at all, that's a problem. Gradual increase in the baseline fetal heart rate. So in the scenario I just gave you with the fetal heart rate baseline being in the 120s, and then over the course of 6 hours after she's ruptured her membranes, now we've got this gradual increase, and now we've got this baseline fetal heart rate up in 168. That's increasing fetal distress. Excuse me. The loss of short-term variability, that's the beat-to-beat variability. So if you'll look at this, this is called minimal variability. See how this looks almost like like a straight line, really. There's very minimal, what they call beat-to-beat variability versus this. You see how jaggedy this is? This is beat-to-beat variability. Means with every heartbeat, we've got a little bit of variability. This has none. It's almost a straight line. Okay. Late decels obviously are increasing fetal distress and persistent bradycardia. If we've got that bradycardia, it goes down, the fetal heart rate goes down and stays down for an extended period of time. That's a problem. That's indicative of some fetal distress, and we need to intervene. All right, this is all still the first stage of labor. Then we get to the in the latent to active phase, the mom is more introverted, restless, anxious, she feels helpless, she may request analgesia or an epidural, and then we move into active to transition phases where we have increasing amounts of bloody show, we've got the urge to push, she's going to be irritable, restless, trembling, vomiting sometimes, crying, they just kind of feel out of control there. All right, now we've got the second stage of labor. So all that was that first stage of labor, dilation and effacement, and then those 3 subcategories in there. So now we're moving on to the second stage of labor, which is called what? No, active is the first subset of the first stage of labor. So this is on to the second stage, the actual second stage of labor. Or sorry, active is the second subset of the first stage. But what is the actual second stage of labor called? Yes, birth, delivery of the fetus. Yes. So second stage of labor is delivery of the fetus. All right, with the second stage of labor, we're going to provide physical and psychological support. We're assessing maternal and fetal well-being. Vital signs, we're checking the heart rate. Oh, sorry. That's a faculty person. I'll call it right. Assess the vital signs, the heart rate and blood pressure every 15 minutes in the second stage. Fetal heart rates, we're assessing every 5 minutes, or we have the patient on continuous monitoring. Usually we have the patient on continuous monitoring at this point. The mom is usually a little less irritable and more cooperative. In the second stage of labor, we need to assess for maternal fatigue because we still got a lot of work to do. So we got to assess for maternal fatigue, using a cool cloth to the forehead or giving her ice chips and just trying to help her relax and be able to get through this birthing process as best as possible. All right, we're going to provide immediate newborn care postpartum, maintain warmth of the infant, assess how the newborn adapts to the extrauterine life. We're doing that with vital signs, APGAR scores, maintaining a patent airway, provide for safety and security. So we're going to footprint the baby as soon as the baby's born. We get footprints, put ID bands on the baby right away, put a sensor on the baby so that they can't be stolen. And we'll talk about that more when we do newborns. And we're going to promote bonding between the parents and the newborn. So we do that via kangaroo care. So where they will, or skin to skin, so they'll have the baby obviously just born. They'll try to dry the baby off a little bit, wrap it in a towel, dry off some of the amniotic fluid and all, and then they'll put the baby skin to skin with mom or dad if need be. Usually they prefer mom, and go ahead and then cover them up with some towels and blankets to try to keep them warm. And we're promoting breastfeeding if the mom desires to breastfeed. All right, nursing role in the third stage of labor. And what is the third stage of labor called? Yes, delivery of the placenta. So we're delivering the placenta in the third stage. So in the third stage, we're monitoring for placental separation. Usually this occurs about 5 to 20 minutes after delivery of the fetus. We're providing physical and psychological care for the mom. The mom usually has a sense of relief. She's delivered the baby. You know, she kind of feels like she's done, which she is for the most part. We need to assess for hemorrhage, so we've got to do fundal checks. So that means we're pressing on the top of the fundus frequently to make sure that the uterus is starting to clamp down, that it's nice and firm in there, that it's not squishy and boggy. And that's what I hate about doing this online, is that you guys aren't going to get to palpate and feel these things, but it'll be kind of squishy. It kind of, what you want it to feel like is kind of feels like a grapefruit, or I mean a melon, like a honeydew melon, or I tell moms like a little basketball in their belly. So it should be good and firm. When you press down on the fundus, it should feel nice and firm there. You're doing lochia checks, so we're checking the vaginal bleeding to determine the amount, the color, the odor of the vaginal bleeding. And we're doing vital signs every 15 minutes for the first hour in that third stage of labor. So this is how you do fundal checks. Fundal checks, you need to, one hand is cupped to massage and gently compress the fundus. So you're pressing on the top of the fundus. I wish I had a model, but I don't. On the top of the uterus here, excuse me. And you're kind of pushing down towards the symphysis pubis. And you should feel literally like cupped in your hand here, like a little basketball or a melon there. And the other hand kind of remains cupped against the top of the symphysis pubis, as they got shown in this picture here. And the purpose of this is to prevent uterine prolapse, so that you don't push on the top of the fundus here and the uterus prolapses. In all reality, that is how you need to know how to do a fundal check. I usually not have this hand here because I'm usually got this hand to pull down their peri pads or perineal pads so I can see the bleeding, because you also need to assess bleeding while you're checking the fundus, because you can be pressing on the top of the fundus. You want to see, is there a lot of blood gushing out of the fundus when you are massaging? Is it firm or not when you go to massage? Do you go and do the fundal check and you check the fundus and all these clots start coming out? We kind of have to assess the bleeding with the firmness of the fundus there. And this is showing you how the fundus decreases. So it's going to decrease. We're not going to stay like big and pregnant looking forever, thank goodness. But it doesn't go down, the fundus does not go down immediately after delivery either. So at the time of delivery, you should, right after delivery, you should be able to feel the fundus right at the level of the umbilicus. And that's where you always start on a fundal check, is start at the level of the umbilicus and move down if you need to. If the fundus is, if the uterus has already contracted some, you move down, but you start at the level of the umbilicus. And then down here, 2 days postpartum, it should be about 2 finger breadths or 2 centimeters below the level of the umbilicus. 4 days postpartum, it should be about 4 finger breadths or 4 centimeters below the level of the umbilicus. 6 days postpartum, 8 days postpartum, and so on. All right, so for the lochia, you're assessing for lochia rubra, lochia serosa, and lochia alba. So lochia rubra lasts from days 1 to 4. Postpartum is bright red in color. It is a fair amount of blood in the shreds of the decidua, and some amounts of the chorion, the amniotic fluid, lanugo, vernix, fatty epithelial cells, and leukocytes. That's what it's made up of. Then you get lochia serosa, which is days 4 through 9 postpartum. It's a pinkish yellowish discharge containing less blood, more serum leukocytes, and microorganisms. And then you get lochia alba, which is day 10 through about 6 weeks postpartum. And it's more of a creamy white color, and it contains leukocytes, mucus, epithelial cells, microorganisms. Lochia serosa can have if it's got microorganisms, it may have a stronger odor. But you're also assessing the amount. So you know, a scant amount of bleeding, a light amount of bleeding, moderate or heavy amount of bleeding here. And it's hard to determine. I have some people that'll be like, oh, I've got a lot of bleeding. And I'm like, well, how much bleeding? And they're like, well, it's kind of hard to say. I'm like, well, if you have, it's hard to say you don't have heavy bleeding, because heavy bleeding, you're like literally soaking a pad within an hour. And until you've experienced that, which unfortunately I have, you don't have any idea about heavy bleeding. But if you have heavy bleeding, you are literally soaking a pad within an hour. Now, one thing you have to be careful of is those little ice packs that we give them. It's little peri pack, little peri ice pack, where it has ice in it, and you pop it and shake it, and it's cool. And we usually put it down in on their perineum to help with the swelling and everything after delivery. Well, those peri packs, those ice packs do not have any, they don't absorb any of that bleeding at all. So it sometimes will look like you're having a lot more bleeding because the peri pack, the ice pack, doesn't absorb any of it. So if you're concerned with bleeding, you need to take off the ice pack and just use a regular peri pad so that you can really determine the actual amount of bleeding. So you have a scant, a light amount, less than 4 inches, moderate amount, and a heavy amount. CC, is heavy bleeding a major issue? Yes, it is. It is a major issue postpartum because of hemorrhage. We're concerned with postpartum hemorrhage. And we can have postpartum hemorrhage for a couple of reasons, and they could be a laceration or a tear to the cervix or the vagina during the delivery process, or something in the uterus, as well as we could have retained placenta where we didn't get all of the placenta out. And if we didn't get all the placenta out for some reason, and we have retained placenta, we will have heavier bleeding and pass large clots. And that's not good. We've got to make sure that we have all of the placenta out and everything. Yes, well, heavy bleeding is not something you should see. You should be seeing bleeding. That's normal postpartum. But usually you're in this, like immediately postpartum, lochia rubra, you're probably in this, maybe this moderate amount of bleeding on your peri pads. And believe it or not, how often should you tell your patient to change their peri pad? Every hour? Not quite every hour. Yeah, every 2 hours, Kelly says. You really want to have them get up and change their pad at least every 2 to 4 hours. And believe it or not, some patients, you literally have to make them get out of bed and go to the bathroom and pee and change their pad. And others, you're like, how often are you changing this? I can't even tell if you're bleeding or not because you're changing it so fast. So it's kind of interesting. But yeah, we really want them to get up and void every 2 to 4 hours, at least every 4 hours, and change that peri pad so that we can tell what's really going on here. Because, you know, sometimes if you go in and assess your patient and you have this heavy bleeding, a lot of bleeding on the pad, and the very first thing you're going to ask is, when did you change your pad last? And sometimes they'll tell you, oh, well, it was, 8 o'clock this morning and it's now 3 o'clock in the afternoon. Okay, well, then I'm not that concerned about having all that blood in the pad at that time. That's when I say, I think I need you to go ahead and get up and go to the bathroom now, and I'll come back and check, in a couple of hours. I mean, I'll be back before then, but in a couple of hours, I'm going to come back and check your bleeding so that I can determine better how much vaginal bleeding you're really having. So you can't just jump the gun if you go in and you see this patient and you're assessing the bleeding and they have this pad that's saturated, soaked in blood. We gotta investigate. How long has it been since you changed this pad? If you do a fundal check and the fundus is good and firm, you're not seeing any active bleeding when you're doing the fundal check, but they say they just changed the pad an hour ago. Again, usually I say, well, why don't you get up and go to the bathroom, change the pad again, and I'm going to come back in an hour or so and check it again so that I can make sure, because sometimes patients really lose track of time. I mean, they're busy, they've got this newborn now, they really have no concept of time sometimes, how much time has really passed. So we're not going to ignore it by any means, but we've got to make sure that we are assessing that we know what we're assessing or the time frame that we're assessing. Hope that makes sense. All right, nursing role in the 4th stage of labor is recovery. So we need to promote parent and newborn bonding. Assessment of the mother, we're monitoring for hemorrhage. So we're doing those vital signs checks, lochia checks, checking the vaginal bleeding, checking the fundus every 1 hour times 4 hours. So we're doing vital signs, lochia, and fundal checks every hour for the first 4 hours. And this is usually while they're still in labor and delivery recovering. Then they will get transferred over to postpartum if they are transferring from labor and delivery to postpartum. And then you're going to do fundal checks, fundal, lochia, and vital signs checks every 4 hours for 24 hours or per the policy. Sometimes it depends. Sometimes they're checking every hour while they're in the recovery area. And once they have determined everything is stable and they move them to the postpartum area, they just go to regular vitals, routine vital signs. So it just depends per the facility. But the point being that you need to check them frequently initially to make sure that they're not having any excessive bleeding. And usually in my teaching, when I first admit a patient over to postpartum, I tell them, I need to know if you're having any large amounts of vaginal bleeding. So if you're soaking a pad within an hour, passing any large clots about the size of a quarter or $50, you know, don't flush it down the toilet, don't throw the pad away. You need to save it and call me and let me come and assess and see what's going on. Monitor the urinary output. Sometimes patients will have problems voiding after delivery for one reason or another, due to the epidural or whatever. So we've got to monitor their I's and O's usually initially after delivery, and we're assessing their comfort level. Now their cramping, they will cramp a lot after delivery. So the uterus will be contracting after delivery. I've had a lot of patients say this feels like labor all over again. Yes, it does, but it's a good thing. And if your patient is breastfeeding, which is what we're encouraging, this will be even more intense. So breastfeeding releases oxytocin, which increases that contractions and cramping. Also, the more children that you have, the more pain, the more cramping you're going to have, because your uterus is a little more flexible. And so it's going to take more to make it clamp down and restrict that bleeding. So, and like I said, breastfeeding is a good thing. And regardless, we're probably going to hang a bag of Pitocin to help to clamp down that uterus and stop that uterine bleeding. But if they are breastfeeding and if they have multiple children, you know, if this is their 3rd, 4th, 5th kid, that cramping with the breastfeeding is very severe. They're in a lot of pain. It's very uncomfortable. And all I can do is really just try to reassure them that this is a good thing. It means that your uterus is clamping down. It means that your body is doing what it's supposed to be doing, and it won't last forever. It's just temporary. It's just going to be until the, you know, the uterus gets nice and constricted, you know, maybe the first week or so, and then it won't be like this, I promise. Perineal pain is a big problem for patients with spontaneous vaginal deliveries or incisional pain if they've had a C-section. So we need to assess that comfort level and medicate as needed. I think pain is next week, so I think we'll be lecturing on pain next week. The mom is usually fatigued, hungry, and self-absorbed. She's ready to focus on her, and she just did all this, and now she's tired. Okay, and it's funny because then you kind of want her to be active and do all this stuff. Well, she's exhausted. Okay. Stages and phases of labor. Yes, page 155 to 156 reviews the stages of labor, mom's responses, and the nursing interventions. And I did look that up during break, and that is the correct page number, so be sure that you look over those. So I did actually get that finished in time, which I'm surprised, but glad. But again, this is a lot of information that we went over. I mean, everything we've taught, everything I've taught since the last exam in particular has had a lot of things that if you guys are not staying on top of it, making flashcards or posters or redoing your notes or looking at your notes pretty frequently, it's going to be really easy to forget this stuff and much more difficult for the exam. So please be sure that you're looking through these frequently. What other questions do y'all have for me? You can unmute or whatever. It's probably easier just to talk.
We have an online assignment due today. Is that going to be under assignments?
An online assignment for,
For 201, it says normal delivery online assignment.
hold on. I gotta find my syllabus in this mess. Let me see. Oh, it's not an assignment, it's just that what's online. I have several videos and, well, mostly videos posted under this section I noticed before I clicked onto it to watch. So it's just that there's just videos that you can, that are to be watched online. There's not actually an assignment with it.
Okay.
ATI. Okay, I was like, I'm not sure, Cecile. I don't think we have ATI due for a bit. We've got, oops, that's not me. I'm looking at the wrong syllabus. Hold on. We've got, next week I'll be doing pain management. And the week after that, we'll have our exam that hopefully, to goodness, we're going to have this figured out because I had an exam today that I've had to postpone until next week until we figure out how we're going to be doing these security exams. But we'll have that exam. And does everybody, I guess, since everybody was able to get on to Zoom, because we may likely be using Zoom, hopefully, for our exams proctoring, you'll have to turn on the camera. Like I noticed most of you turned your camera off, but you'll have to turn on your camera to do proctoring. And that's what we're thinking we may be going to. We're looking into a lot of options, but we're thinking that we may be somehow using Zoom. So most of y'all have camera option, I'm assuming, that you can turn on to do exams via Zoom. Yes. All right, Victor, are there any meds given in the 4th stage of labor to promote comfort? Not specifically, but we'll talk about more about pain level things next week when we do pain management, Victor. And I think this is Robin. Are we still on for presentations, or is that still up in the air? No, I think we're still going to do presentations. The presentations needed to be done, like if you had a PowerPoint or a paper pamphlet or whatever, it needed to be uploaded to Blackboard anyway. So I think that we will still do that. I'm still kind of tossing it around, but I'm gonna tell you, the presentations have been so beneficial in the past for the students in the past, and I purposely leave out some information because I assign it for these presentations. So my plan is to still keep the presentation. You all will just have to try to meet like we're doing now on Zoom. Anybody can create a Zoom account and start a Zoom meeting for your group to meet. Everybody just sets up a specific time to meet so that everybody can get on at the same time and discuss your presentation. Probably would be best if it's done maybe via PowerPoint now. Or it doesn't have to be. Even if you did a pamphlet or a brochure, you would just upload that and share it, just like I'm doing with the PowerPoint, but you would just share the pamphlet or brochure and record it and send it in. So the things is, I think give me till the end of this week to verify that, because I've got something going on in first semester where they're all going to be doing a recording thing and sending it to me for grade. So I'm going to say give me till the end of the week to let me verify that. But as of now, yes, I'm still planning on the presentations. I will let you know 100% by the end of the week. Good questions. Any other questions? No? Okay, well, I'll just say keep watching your emails frequently and your announcements, because things are changing a lot. I mean, things are changing fast. I know this wasn't ideal because it takes me a while to be able to get the message from the chat and back and forth, but I like at least being able to interact a little while. I mean, it takes me longer because I have to wait longer to get the response, so it's kind of awkward, but I like it better than just sitting here and lecturing to you without getting any answers back. So any feedback you can give on that, I'm appreciative. Thanks, Kelsey. I'm glad to hear that it helps you this way. Kelly saying, yeah. Yes, be sure you're using good hand hygiene, washing your hands. I do my daily cleaning of the doorknobs and the sink faucets 2 or 3 times a day, because I can't get my kids to understand that they're actually supposed to stay in the house and not be with 100 other people. Although they kept it down to 10, it's still too much for me. So I just go through and clean all the doorknobs, have hand sanitizer all over the house, and trying to keep them all healthy. You know, keep watching. I think I'm going to try to do, some type of Zoom office hours potentially. I'm not real sure how I'm going to work that out, but some type of video office hours. But if anybody, you know, if you want to talk about something, all you need to do is just let me know, send me an email or a text, and we'll get on Zoom. I've had a couple of meetings with students via Zoom, and it works out nicely. You don't got to be all dressed up. You can be in your pajamas still. I don't really care. But I like being able to see you while I talk to you. It makes it nicer. So while I won't be in the office, obviously, and neither will you, I do like being able to see people. So, you know, all you gotta do is let me know that you want to do that, and I'm happy to set up a little Zoom meeting that way. I think that's it. Like I said, there's going to be lots of emails, lots of announcements as we learn things and figure things out. And, you know, feel free to ask questions about anything that y'all have questions about. Okay. Are we anticipating what? Sorry. Oh, you know, I have no idea. I am anticipating this for the rest of the semester. Yes, I have not been told that by any means. No one's told me anything. I know as much as you all do. I am basically anticipating it based on my own children's colleges. I have 3 kids in 3 different colleges, and all 3 of them have gone to online for the remainder of the semester, and not including UK. So I am just anticipating it based on history of my personal experience with my kids. No one from BCTC has told me anything. So I'm sure I'll know as you all know. But I'm just anticipating it, yes. So again, any feedback you all want to give me, you can shoot me an email. What was helpful, what wasn't helpful, if there was anything that would be better for doing this lecture. I did like doing it live, and you know, it'll be recorded for those that couldn't join, and we'll go from there. All right, well, I'm going to go ahead and stop this now, but if you have any questions or anything, then definitely, you know, just send me an email and get back with me. And good luck on the rest of the day.